like to offer kind of a preliminary overview of our investigation, and there's more results forthcoming. So most people, when I tell them I work with monkeypox, think that I'm a veterinarian that works in a zoo, but it's actually a human disease. It's a living relative of smallpox. It was discovered first in primates in 1958, which gives it its name, and then wasn't found in humans until 1970 during the course of smallpox eradication. It does have an unknown wildlife reservoir that is likely not a primate. It's probably a rodent. My guess would be a squirrel. And it does cause a typical orthopox rash illness with the firm, deep-seated nodules that are led by a federal program. There is no specific treatment other than just supportive care, but smallpox vaccination is thought to offer a protective effect. And again, those were stopped in 1980 with the eradication of smallpox. The mortality rate's been reported between 10 and 30%, and there is significant morbidity, including blindness, involved with the disease. And then human-to-human transmission is also possible. We had these stuttering chains of transmission of 3 to 4 human-to-human events. And then it's very difficult to distinguish human monkeypox from varicella in these regions, which has led to issues in reporting. Looking kind of at a coarse scale of human monkeypox, I think the most important thing to note is that for most people it's essentially zero. This is a disease that's highly restricted to Central Africa, primarily DRC, ROC, and Cameroon. There are some, another strain in West Africa, and other than a few random importation events, it's mainly restricted to very marginalized, impoverished populations in the forested Congo Basin. After smallpox was eradicated, there was an interest in seeing if monkeypox would sort of fill the niche vacated by smallpox, so there was intense surveillance during that time. They estimated the incidence rates of monkeypox were about 0.7 per 10,000 people. After about 5 years, they decided there was no risk for that to happen, and surveillance was discontinued, where we entered sort of the dark ages of monkeypox in Central Africa, where for about 10 years, 15 years, there was no routine surveillance. In the mid-2000s, with increasing interest in emerging disease, some researchers from the University of California, Los Angeles, Anne Ramoyne and her group started revamping active surveillance in some areas of the Congo and found that rates had increased 20-fold, up to 14 per 10,000 in some areas of the Congo. And then the DRC Ministry of Health has recently set their rates at about 4 per 10,000 cases. In 2010, the CDC initiated an enhanced surveillance system with the DRC Ministry of Health and some of their academic partners. And again, our focus was on building surveillance capacity across the entire country with a specific focus on Tshuapa district, which is an Equator province in the northwest of the country. So we provided laboratory support, materials for collecting samples, and then a standardized case definition and reporting form. Specimens are collected and they can be tested by PCR at the National Reference Laboratory. We've done some infection control for healthcare workers, and then there are also ecology and health education aspects of this as well. Again, Tshuapa district that we talked about, it has historically reported lots of cases of monkeypox, sporadically reporting them even when no active surveillance was going on. Again, it is a heavily forested area of the Congo Basin. It's estimated about 1.7 million people reside there, and it's 135,000 square kilometers. So it's about the size of Greece. So it's essentially a country in the middle of the forest with about 300 healthcare workers and 190 health posts scattered through there. Most of these health zones have one physician who serves as the public health officer for the county, the administrator for the hospital, and their primary surgeon. And there are hundreds of kind of one-room health posts that have very limited medications and resources to provide care. And then we did establish a coordination office in Bowende in 2009, shown there. Sorry, and one other thing, even in Tshuapa, from the data we've had there from our enhanced surveillance doing training every year, we still see these highly variable rates of monkeypox incidents. Some counties reporting 0 to 2 cases, some reporting 6 to 10. And so one thing that I think the chair touched on earlier is sort of the lack of geographic resources in this area. When I was working in one of the clinics one time, they had this map taped to the wall. It's done in Microsoft Paint, if anyone's familiar with that. and they had just done it themselves and working with other healthcare workers. It turns out all the people in these districts, they all have something similar to this for their health zone. They spend their days traveling by motorcycle and bicycle across these roads, doing vaccination campaigns, polio, things like that. So they have a very good idea of the geographic resources in their area, but very limited ability to kind of display them correctly. So we've been working with them. We essentially, we print out paper maps of their zones with sort of the digitized roads on there, and we let them mark up the maps with pen and paper with the towns and the clinics and where they're doing things like that. And then we bring them back and we can scan them in and digitize them to create a better map, which we provide them next time. It's sort of an iterative process going on and on. Again, we can use land cover data from the area, so you can see where human habitation occurs. And sort of we can adjust the points they put on there and show them, where they are in actual time and space. And it really helps to put a name to the place. We can look at satellite images remotely sensed from anywhere in the world, but we have no idea what village that is, how many people live there, what kind of medical facilities they have. And getting that information from the healthcare workers and adding it to these remotely sensed resources is really valuable to us. So from that, we've been able to establish the location of 216 clinics and health posts in this region, which are shown there. And with that sort of data, we're able to kind of move to a finer scale of investigation. So we know the health posts. We can combine that data with the case forms that they're filling out and determine which health posts are reporting cases. We can kind of assess the size of those catchment areas and determine where in this district we're having the most cases of monkeypox. And so you can see, even from the map I showed earlier, even within those zones that have higher incidence rates, within that zone there's another degree of heterogeneity in terms of case reporting. So some areas, clinics report more than 10 cases per 10,000. Some still entire zones reporting none at all. Another way we've been able to use high-resolution spatial imagery. In 2013, there was we were notified about an outbreak of monkeypox. That's probably a residual from our surveillance system. One health center reported 8 times the number of cases in a 3-month period than they had in the entire year before. So we initiated an investigation. We were able to go investigate cases at their houses, take GPS coordinates, do case control studies, other epidemiologic activities. And we did identify 9 household clusters of monkeypox. And again, these probably represent 3 separate introductions where there was an extended period of time and then another epizoonotic event to do that. So we were able to mark the locations with GPS. Going back with the high-resolution imagery, we're actually able to capture the location of kind of every structure in the town for comparison. And using that, we're able to do some more kind of fine-scale spatial analyses that weren't possible before. So we've classified Landsat imagery into land use. So you can see the disturbed area marked here in red, the developed area marked in red, disturbed areas shown there in yellow on the left-hand side, and the forested areas. On the right, we've used that marking of houses to kind of as measures of population density, showing where cases occur. And we found that in a 100-meter radius surrounding the homes, there's really no difference between where we have cases and basically the town in general. But when you expand out to 500 meters, you see that case households are likely to surrounded by disturbed areas and less likely to be surrounded by forested areas, which there are several hypotheses for introduction of monkeypox, one of which is kind of human interaction with these rodents in disturbed habitats, so that somewhat supports that. And then we also found that, as you were mentioning before, where malaria would be found, at the edges of the village, we're really seeing cases of monkeypox kind of scattered throughout, and even in areas that were densely, had high population density, you still see cases there. So there's lots of factors at play here. So just some quick conclusions. Again, measuring the incidence of monkeypox is trying to hit a moving target. The waning immunity from smallpox vaccine, it's been 35 years now, is probably causing an increase in rates. Again, the ability of healthcare workers to recognize symptoms is crucial, and distinguishing that from varicella. Again, there are lots of interactions between humans and the landscape that are involved, and there's a large number of uncontrollable factors. For example, sometimes we have a health zone that reports consistently lots of cases of monkeypox, and then nothing for 6 months, and it turns out their motorcycle was broken, so they were unable to do any investigations for 6 months. Again, improving the quality of spatial data will help us out a lot in creating enhanced metrics. And then, again, just the capacity, my plea here at the end is a definite need to increase capacity for public health. Just this year, not this year, just a few months ago, Burundi has reported 70 cases of Ebola within weeks of when they occurred versus months that we saw for West Africa. I would like to think that's partly in part due to our enhanced surveillance activities here, that the public health workers could recognize, public health anomalies and get them reported in a timely fashion. I'm actually headed there on Sunday from here to work with that. Again, this work involves a lot of colleagues, both at CDC and with the Ministry of Health and DRC, INRB, which is a reference lab at the Kinshasa School of Public Health. And with that, I'll close. And again, it's a team effort. It takes a lot of people to get your car out of the mud, so I appreciate everyone that's helped us with all of this work. Thank you.